This is a 29-year-old male who presented with breathlessness. He had a mitral valve replacement with a 25 millimeter mechanical valve in 2012. 4 years later, he got a mitral prosthesis thrombosis. He was thrombolized. 2018, again it was thrombosed. Again he was thrombolized a second time. The third time, when he again presented with a third episode of thrombosis, the surgeon changed the valve in 2008 towards December to a second mitral valve with a mechanical valve. During the follow-up, he was noted to have severe mitral paravalvular leak. He had right heart failure. He had pedal edema. He was on multiple diuretics, Coumadin. Next slide. So he had features suggestive of heart failure, was weighing 49 kilogram. Next. He had a reticulocyte count which was slightly higher. He was like being treated for an anemia as well. His bilirubin was marginally elevated. LDH was slightly higher. The predominant problem was heart failure. He had a dilated heart. Next picture. ECG showed sinus rhythm. Next. The echocardiogram showed, this is a good view, an apical four-chamber which shows a large gap on the lateral mitral annulus. If you carefully look on the left ventricle basal lateral wall, it is dyskinetic, aneurysmal, just below the paravalvular leak. The color flow shows the leak from that area. You can appreciate the basal lateral wall dyskinesia. Next picture. So there was significant pulmonary hypertension with an RV pressure predicted of close to about 90. This was a patient with a mitral paravalvular leak. He had a mechanical valve, and then he got it replaced because of mitral valve thrombosis about 6 years later. The last surgery was done in 2018 December. He was identified to have a severe paravalvular leak. Go to the first frame. Now, with the transesophageal echocardiogram show the last transesophageal echo. Or Srijak, can you describe the TE pictures? Go to the first frame. Is the audio better, John?
Yeah, we can hear you.
Okay. Now we are showing. Can you show the echo live? Echo big.
We can see.
Echo.
Yeah, we can see and echo.
Make the echo bigger. Echo screen bigger. Prabhu, make the echo screen bigger. Okay. So what you are seeing is the initial recording that was done. So you can appreciate the basal portion of the lateral ventricle was not contracting very well. And that was the same region where the mitral paravalvular leak was there. Next picture. So this is the valve, the flow through the valve. There was a higher mitral valve gradient due to the regurgitant volume passing through the mitral prosthesis. So here we are visualizing the leak. We can see some of the torn sutures. Next. So you can appreciate it far better. There is a large defect, and this is the severe paravalvular leak. Then next, so it was quite lateral. It was close to the left atrial appendage, and it measured about 15 millimeters. So we actually wanted to do the transeptal puncture online. However, since there was a delay, we punctured the septum. What you are seeing here, camera big. Yeah, but this was the left atrial pressure when we got. There was a mean pressure of close to 30 with V waves going to 65, and the red line is the aortic pressures, which was around 95 systolic. So there was quite a substantial mitral regurgitation causing tall V waves. The pulmonary artery pressures were around 80 millimeters systolic when the aorta was about 100 millimeters systolic, around 80% pulmonary artery pressures. So then we were interested to know what was the reason for that basal aneurysm. So first fluoro big. Yeah, we first confirmed that the leaflets are moving normally. So this was the normal bileaflet mobility of the mechanical valve. Then we wanted to see the circumflex territory. Next. So this was a circumflex injection. We can appreciate that there is a myocardial bridge on the large obtuse marginal. This myocardial, freeze it and show diastolic and systolic frames. Yeah. Now that is the diastolic frame. The diastolic frame, the vessel opens out. Show the next frame. Next. Okay, during the systole, there is a long squeeze of the OM branch. Next picture, next frame. So we changed the view and we looked at the OM branch again. Freeze it and show. Yeah. So in diastole it opens out, and in systole it is collapsing, and this has possibly led to a basal lateral infarction. Next, keep going. Next, you can see that it's quite a long myocardial bridge, but in diastole it fully opens out, and this is resulting in a significant basal lateral left ventricular aneurysm. And now Srija, can you show that image that you got where the basal aneurysm was seen and the leak was seen? Yeah, now see the echocardiogram. It is the dyskinetic area, exactly around the dyskinetic area was our leak also. So the next thing that we did was show the next picture. Yes, yeah, this is a LAO projection. You can appreciate that there is a long myocardial bridge almost across the entire, going across the left AV groove. Go back, show in diastole. No, show the same. Yeah, freeze it during diastole. Go back. Yeah, in diastole it completely opens out, and in systole it collapses. We can also appreciate the bulge of that circumflex area caused by the aneurysm. Next frame. So then we did a LV angiogram in order to find out that aneurysm. You can see the basal part of the aneurysm. Freeze it. You can just, yeah, next frame. Next, correct. You can see that this is a systolic frame. Next frame. Yeah, during this, correct, freeze it. During the systolic frame, there is a complete dyskinetic bulge on that basal lateral area. So it's possible that this area of dyskinesia is causing a stretch on the annulus, and probably that might have been the reason for the paravalvular leak. Z and Varakan, your thoughts, please.
Z?
Yeah, this is pretty complex because, as you can see, you have different pathologies. You have, three pathologies. You have the leak, you have the aneurysm, and you have the myocardial bridge. Obviously, the classic treatment for the bridge is surgery. They have to do surgery to free that coronary artery. The aneurysm, I don't see a specific nick so that you can, try to close it percutaneous, using a device. The leak is the least of the problem to close in the cath lab. So I would just tackle the leak here and then refer him for surgery so that they can tackle the coronary artery and maybe do something for the aneurysm.
Siva, do you have any other imaging on this patient? CT, MRI, anything?
No.
No, so
no,
it's just this.
No,
Anyone else want to comment on this very complex case? Is Alison in the room still struggling to see? Alison Kabelki?
So the thing is, we don't know the viability of the basal lateral wall. What is the viability? Obviously we may have to do some viability testing, and if there is a viable territory in that lateral wall, we can think about an off-pump venous graft towards that circumflex territory. However, whether the basal part of the left ventricle will get revascularized and whether it will get again an improvement in the myocardial function is not very clear.
Okay. Yeah, I agree. I think, you need to assess the viability of this myocardium by gadolinium, maybe MRI, and deal with that. But for right now, one of the acute problems is the paravalvular leak. So at least if we can eliminate that significant leak, at least the surgeons, they can pause and come up with a plan to tackle the coronary artery and the aneurysm.
Okay.
Yeah. Hey, Shiva.
Yes.
This is Zaid.
Hi, Zahid.
Curious. Hi. Very fascinating case. Did you see any echocardiographic finding of this aneurysm?
I showed in the PowerPoint presentation there was a basal lateral wall aneurysm, exactly corresponding to that area.
Gotcha. And second is, I have never seen aneurysm formation secondary to myocardial bridging. That is confusing to me. What's the cause for this aneurysm formation? Because myocardial bridge can cause chest pain, you know what I'm saying, but it has not. I haven't seen it causing a aneurysm formation.
Okay, when we saw the first the basal lateral wall aneurysm, there is a type of an endemic disease that is seen in patients from Asia and Africa, which is called submitral aneurysm, which is a focal outpouching of the basal portions of the left ventricle along the posterior mitral leaflet base, and it causes an aneurysmal bulge of the basal wall of the left ventricle, and this is known as submitral aneurysm. It's commonly reported in countries like Africa, in Asia, especially India. So we were thinking whether it could be a submitral aneurysm because he's a very young 29-year-old person with no coronary atherosclerotic risk factors. He never had a coronary. Yes.
Yeah, Samir, do you want to make a comment? Is Samir here? Yeah. Do you want to make a comment on this? You guys are in adult cardiology. You must see this quite often, the bridge and the aneurysm. Can you make a comment?
Go back and show the myocardial bridge. Yeah, run it. Yeah.
So let's see the myocardial bridge again one more time, please.
Yeah.
And there is the picture of the myocardial bridge. There was a better picture than this, but
yeah, the previous one.
Yeah, no, I think if there's no
this one.
This is a pretty common phenomenon. I feel like if there is not an angina component, this part can be left behind for now, and then you just take care of the leak as you are doing. This is the only times I think this becomes something that we really pay a lot of attention to is when there is compression from PA or other structures, and that is causing the bridge. And then it becomes, I think, more of a surgical issue. But for the most part, I think you stay away from this, don't stent it, don't put metal in that area. That is probably the best approach.
So, Siva, I think we're all pretty clear that we should just concentrate on the leak now. This is a big hole.
Srija, show the same picture again. Show that same leak picture again. Okay, Z, another. Now the question is about the leak. It was a 15 millimeter leak. Just show the previous 2D, Srija, the previous 2D. The 2D picture that you are just like you were showing a short while ago. Just the previous. Yeah, this is the picture. See, this is a leak that was measuring 15 millimeter between those two edges, 15 to 16 millimeter between the two edges, and it was measuring the same on X plane and Y plane. So it was more of a circular paravalvular leak, which has got a measurement of between 15 to 16. So what sort of device would you choose? Since the left ventricular, like the entire almost stroke volume is passing through the mitral paravalvular leak into the left atrium, causing a very high LA pressure, I was thinking about a relatively sturdy device. We have options of vascular plugs or some of the sturdy. Yes.
Just wait, let's ask the audience.
Yes.
So, see, what would you use?
I have two options here. I would use either the Occlutech PLD rectangular device or the AVP3. Both of them, they should do a good job with this defect. Probably I would go with the Occlutech because of the large disc covering a larger surface area.
Okay. Z, the question is, it is a 15 into 15 millimeter, almost circular, and the largest rectangular PLD device is 18 into 10. So it will have a long axis 18 and a short axis 10. So if you are putting an 18 into 10 on a 15 into 15 leak, there will be some sort of edge residual flows, and we have used the PLD device on few patients. And if there is a residual flow due to edge leak, it continues for longer periods of time. It doesn't stop. Since it was completely circular, a rectangular PLD device I did not think was a good option. We looked at the options of square device.
Siva, let's let the audience make a few comments.
Yes.
Hang on.
Yes.
Shaq.
From the shape of this defect, do you think two square-shaped Occlutech devices with the waist may fit in nicely?
Since it was circular, Shaq, I was not thinking about two devices. See, if it is oval or crescentic, we think about 2 or 3 stacking them together. But this was very circular. So when it is circular, then you try to think about something like muscular VSD or a PTA or one of those circular devices.
Yeah.
In fact, if there was a square type large device, I would have chosen. But the square type diameter stops at 12. There is no device more than 12.
Siva, I think Shaq's point was, yeah, I get the idea about the circular lesion, but the overall, let's say, encroachment on the valve is likely to be more if you use a single big device and two smaller ones. Is that your point, Jack?
Yeah.
Yeah.
Okay.
Anyone? Alan?
What about a muscular VSD device which will have a 10 millimeter separation between the two discs?
Yeah, I agree about a device that will be quite rigid because there is a lot of pressure difference and the defect is quite large. So either a big Occlutech PVL or a muscular VSD.
Okay. Now, one of the concern about using a muscular VSD device, if my device is going to squeeze further the circumflex artery, so I should be having a circumflex check angiogram when the device is in, and if there is a worsening of the coronary compression, then we probably cannot put a muscular VSD. We may have to take it out and then use some softer device like AVP2. AVP2, a single 22 millimeter device, is, I think, will fly because the force of ejection through a large 15 millimeter orifice is quite a lot. But maybe two AVP2 squeeze in together so that they just get entangled there. That may be an option, but as a first choice, I was thinking about using a muscular VSD device.
I agree with you, Sivakumar. I think for this 3D image that you showed beautifully, it's circular defect. I think a muscular VSD device should also work in this particular picture.
So what I am taking now is an Occlutech muscular VSD device. So focus on my hand. The advantage of a muscular VSD device against the other competitive brands is that it has got the tilting angle. So if there is a mitral paravalvular leak that we are closing with an Amplatzer or a LifeTech or any other muscular VSD device, there will be a tension on the cable, whereas I feel the tension on the cable is going to be very less. So this I'm loading it onto the sheath, and then I'll do it now under water.
Can we keep moving, Siva, to go back to Frankfurt fairly soon? So if you can perhaps...
actually, the sheath is already in, so I'll show you the...
What sheath are you using, Steve? Just explain. You've done a transeptal puncture and you have what in the left atrium? Is this just a Mullin sheath, or
yes.
do you have something else?
Okay, don't show the next pictures. Next, no, after this. No, can you show the previous? Should go slowly. Okay, next picture. So then what we did was we took a sheath on the front of the body. This is not actually within the heart. This is on the front of the chest. We wanted to see that we actually put an echo navigation on the tip of my sheath actually is on the paravalvular leak. We oriented the sheath and we found that the place of intratrial septal puncture site. Srija, can you put no, we cannot have, we don't have a marker there. So we just wanted to see whether the echo navigation site of atrial septal puncture was correlating with the external, like the sheath position. The next picture, the next fluoro. So then we came down, we did the septal puncture. Next, and after the septal puncture, we entered into the left atrium. Corresponding to that area of the left ventricular aneurysm, the left atrial appendage was also aneurysmal in that area. Next picture. Then we took a standard right coronary artery catheter, and the right coronary artery catheter, the wire was initially going couple of times towards the left atrial appendage. However, subsequently it dropped into the left ventricle. Next. So after it, okay, this is actually, I think, in fact at this particular time we wanted to go live. So then again I recrossed. Next picture. So then this is the catheter. Next. Initially I took a soft non-braided Mullin sheath. Next. Next. So this was initially it was a 10 French non-braided Mullin. However, that was kinking, and so now I have put a flexor sheath 10 French. So this is the position where we are currently in. So echo big, Srija. Can you show the echo without the 2D? Yeah, 2D. So now we are having the echocardiogram. The sheath is completely seen now on the echo. I'm going to.
Can you enlarge, Siva?
Yeah,
can you enlarge the echo picture? So we've got your fluoro on the left and a large TOE on the right. We don't need to have two fluoros.
Can you see actually the right side of the screen is live live echo, and the left side of the screen is fluoro. Both are this is a very large screen, and we are showing both sides parallel side by side. maybe one
Carry
thing,
on then,
you put only this. Take. Yeah. Now is it okay?
Yeah, that's fine. Go, carry on. Let's
Okay.
see how you get
So now we are trying to approximate the aneurysm. I'm coming progressively higher. So this is a 18 millimeter muscular VSD device. The leaflets are still looking okay. So at this point, I'm planning to open out the disc. The advantage of the Occlutex tilting cable is that it is not offering any tension. Now I will slightly come out. Yeah, see that it is reasonably well aligned. Now we are carefully checking. Can you zoom on that valve now? Fluoroscope assess whether there is a valve. Mobility is fine. Okay,
looks staggeringly good for such a huge device and such a huge hole.
Yeah. Now, Srija, can you look at the residual leak? I will make a circumflex angiogram now to find out whether the circumflex is getting compromised further. Can you come to AP view? Is this LCA?
Yeah, we can see you. So the TOE is the thing we're interested in now. So you can just show to us whether there's any residual leak.
Okay. So now I'm going to do the circumflex angiogram.
Let's just concentrate on the device and just show us, get your echocardiographer to take us through a few views of the TOE, so the audience, this is nicely included. It looks very, very good.
Rija, can you show the leaflets nicely? So the leaflets, zoom on the leaflets, Rija. Yeah, just rotate. I think the leaflet mobility seems to be okay. Can you check the gradients across the valve now?
There's no MR, there's no paravalvular leak. I think it looks very good.
What do you think, Shaq?
Sorry, I missed the question.
Ziad, can I have a question? Or comment?
That looks very
Siva.
good. That looks very good. And circumflex angiogram would change as well. So,
can you put a thermowire here?
Siva.
Yes.
Absolutely fantastic. Do you want us to come back, or can we leave you now after this case?
I'm going to show you the transmitral gradient now, so that you can see the catheter gradient between the left ventricle and the left atrium.
John, question up here.
So,
yeah, Siva.
Yes.
It looks good, but I'm not sure whether the stability with the device is quite stable. Will you consider a bigger device? Because I think the issue of compromising the valve probably is not there. The orientation is slightly different away from the valve. I'm a little bit concerned about the movement of the device. Maybe should we consider a bigger device?
I'm worried about a very, very large device that will cause more stretch on the circumflex. But it seems quite stable to me. There is a complete abolition of the gradient. This is the mitral gradient. You see that it's reasonably looking okay. The left atrial pressure has come down from 30 to 14, 30 to 14 or 13 maybe. It's quite
Siva, I think that looks a great result. Are you happy with it?
If
you are, I think we'll ask you to try and move on and release the device so we can get back to Frankfurt.
I'm just releasing the valve. The question about Varakan talking about possible stability, it looks stable to me. So can you get the same view where the leaflets are nicely seen? So now we are going to, Srija, you are happy about the valve? Okay. So we have released. I'm slightly pulling the sheet.
It looks wonderful, Shiva. That's a great demonstration of how to use such a big device to treat the paravalvular leak.
Very good.
Yep.
Okay, Siva, I think what we'll do is we'll go back to Frankfurt. We'll maybe pop back into you.
Okay, thank you. Thank you.
Thank you. Just show us anything more from this to clear up. But that's a wonderful case. Thank you very much. And if we can go over to the CVC.
Great case.